Dr. Linsky said, I couldn't find a whole lot of stuff about you. And I said, well, I don't want you to steal my thunder, so I'm actually going to give you a little bit of information about myself, where I came from, kind of my roots, if you will. So, does anybody know where Hurricane Utah is? Shauna, you don't know where Hurricane Utah is? Okay. All right. Well, Hurricane Utah is about 30 minutes outside of St. George, or I'm sorry, 20 minutes outside of St. George, and it's near Zion National Park. That's where I grew up. So it's a very small southern Utah town. I did live in Chile for 2 years in a service capacity. My education included multiple universities, but I got my degrees at Brigham Young University. BS in microbiology, management chemistry, and Spanish. So I got married in 1977. As Dr. Linsky said, I have 4 children. I did my Baylor, my dental education at Baylor Dental College, also my perio training. Specialty training, a lot of times you go to a specialty program and they'll concentrate on one aspect of periodontal therapy, either aggressive or conservative. I got a little taste of both, which I was great for. They also have what's called a stomatology center, which is the study and treatment of oral disformative conditions. And so I received quite a bit of experience with those kinds of issues. I'll show you some slides here today. Did a master's thesis in relationship to lingual nerve and periodontal surgery. Moved here in 1986. I have 3 sons, 1 daughter, none of whom which are in dentistry. They started out, but you know how with any specialty school, any higher education, you got to enjoy what you're studying. They just didn't get along with biology. So, hobbies: digital photography, gardening. I have to tell you, I had a neighbor come by my tomato plants the other day, which are now about 6 feet tall, and he accused me of using nuclear active soil. And I promise you, I do not have any nuclear in the soil. Love fishing, scuba diving. And, I think we have probably one of the greatest professions in the world. I think dentistry is just awesome. The opportunity to work with the public, in my particular area, one of the things that I enjoy the most is the interaction that I have with my patients. I'm really, and I think there's been kind of a transition in the last, thank you, hypoglycemia, here we go. The fact that we can interact with the public, that we can provide them with care that's going to give them better health, the fact that we have an opportunity to educate and be kind of co-assistants to the medical profession, I think is awesome. So it's interesting because the first email that I got from Dr. Linsky was about the topic, and I have to admit that the email was sent to an email that I rarely use, so I read it once and I got in my mind that this was all about periodontal disease and diabetes, having nothing to do with nutrition. And so I got the email a couple of days ago, so I had to do some quick changing. So anyway, there's a lot of information here. I have to give credit to some of the websites that I went to, like the National Institute of Diabetes Education. But as we treat our patients, one of the things that was instilled in me in dental school, and I'm sure it was with you and in your practices, and that is that we're not just treating the mouth, we're treating the entire patient. And so with that comes all of the patient's issues, medical issues that we have to be aware of and know how to provide safe care to our patients. So here, and I have to also say, this patient was in my perio training, actually came into the stomatology center at Baylor, and 35-year-old male smoker, had diabetes. His chief complaint was, I have just a lot of pain in my jaw. This actually is a slide showing him after he was cleaned up a little bit, so this is not the way he came in. I wish I had that picture. But I want you to kind of get an assessment of this 35-year-old male. Okay, so here you see a lot of inflammation. Actually, he's healing, but you notice the areas where we have like no bone. So does anybody have an idea of what this patient might have come in with? What would cause something like this? It is a form of periodontal disease, but it's not a chronic form, it's an acute form. And I have to say that in my practice, I haven't seen a case of ANUG since I've been in Santa Rosa, but this was a case of trench mouth, another name for ANUG, acute necrotizing ulcerative gingivitis. And what had happened was, when he first came in, and this photo was probably taken about a month later, he actually had exposed bone. The tissue had just been destroyed. The carotid slept away, bones was exposed. And so when that bone came out, the bone died, he had these huge craters that he presented with. So, a couple of things, you know, he was a smoker, he had a systemic issue, diabetes. We find a lot of patients who are in this category don't take good care of themselves, and this is what transpired. This patient, 65-year-old white female, presented with chief complaint, my teeth are loose and it's too painful to brush. So you can see there wasn't very much brushing going on. But you can also see that there's a definite reason why she has pain. You can see the chronic acute erythema that she had. Something else is kind of a tip-off here. I don't know if you can see, but there's little scarring of the conjunctiva to the eyeball. That's also an indication. Plus, she had a systemic issue of rheumatoid arthritis, which is an autoimmune disease. Here, another kind of sign or an indication of what your differential diagnosis might be is if you were to take a piece of Q-tip or gauze or even an air or water syringe and blow air onto the tissue, the outer layer would peel back. Does anybody have an idea what this might be? And this is another indication we have in the maxillary tuberosity area. That was a fluid-filled sac that, when touched, you know, it just broke open and the fluid came out, and there was an erythemic red spot underneath. So, and this is after some treatment. So this patient came in and was diagnosed with pemphigoid, which is also kind of a systemic issue. Pemphigoid patients need to be followed by an ophthalmologist. They have periodontal disease because they can't brush their mouth until they get treatment. And a lot of times the treatment is oral topical steroids and things such as that. So anyway, I just thought I would start with that. So with diabetes, you know, we all know about diabetes and that there's generally three types. Type 1 is an absolute deficiency of insulin. Death of the beta cells caused by an immune phenomenon that the patient has builds antibodies against the beta cells of the pancreas. And type 2, which is a result of insulin resistance and then gestational. We know that patients who have diabetes also are more prone to cardiovascular disease. 68% of those patients die of heart disease or stroke, and it's 2 to 4 times greater in those patients than the average population, and then 6 to 7% have hypertension. So these patients that come into our practice obviously are at risk if we don't or are not aware. I mean, there's some other statistics in here that we'll go over, which is pretty impressive. And then if you add smoking onto that, it doubles the risk of heart attack. Diabetes complications, kidney failure is a great one. 48,000 people with diabetes began treatment for end-stage kidney disease. New cases of adult blindness, 4.2 million people between 2005 and 2008 had retinopathy. And then this other thing kind of like blew me away when I found out that there were 65,000 amputations, leg amputation, performed in 2006. And these were because of diabetic complications. So this disease is pretty nasty, actually. And then in our area too, obviously periodontal disease, people are 2 to 3 times higher likely to have diabetes, periodontal disease if they have diabetes, and then 1/3 of those people have a more aggressive form of diabetes in severe periodontal disease. Nerve damage, impaired sensation in feet. Also, people with diabetes are twice as likely to have depression. And this is interesting too because insulin-dependent diabetes only accounts for about 5% of the diabetes in the population. Type 2 is much, much greater, and that accounts for 90 to 95% of the population. gestational diabetes, interestingly, 7% of all pregnancies are affected by gestational. Those that get gestational generally have an underlying type 2 undiagnosed diabetes that they've experienced, and then those people who don't actually develop diabetes 35 to 60%, 10 to 20 years later. And this is kind of getting to the meat of what we're talking about. So, I don't know, I want you to ask in your mind, what is it, why are we seeing such a huge increase in type 2 diabetes? You know, what are some of the causative factors? Here's kind of a diagram showing that from 1994 to 2008, we've seen a steady increase in obesity. Okay? And at the same time, we've seen a steady increase in the diagnosis of diabetes. So they're correlated. Obesity is defined as a body mass index of 30 or greater. I kind of take exception to that because my body mass index is like 28, so I'm close. Number of people that have diabetes 20 years or older, we see that there's a huge number, 1 in 4. And in 2010, there were 1.9 million new cases of diabetes that were diagnosed. So we can see kind of a trend here. I'll go over some other information. Here we have an ethnic relationship, American Indians. This kind of blew me away too. My daughter lives in Mesa, Arizona. But here it says that almost 1/3 of the American Indian adults in southern Arizona have diabetes. So that population is affected far greater. African Americans are 77% more likely to develop diabetes than non-Hispanic whites. And in that population, there's almost 1/5 of all of them over the age of 20 that develop diabetes. So we have 11.8% of Hispanics and Latinos. That's broken down into different areas of the world. Asian American Pacific Islanders, 8.4. So I'm going to go through these slides rather quickly here, but type 1 diabetes is the most common diabetes of children, ages 0 to 10. People younger than 20 years of age, type 2 diabetes is more common. I'm sorry, type 1 diabetes is more common, type 2 is more rare. Why would you think that would be? Type 1 more common, type 2 more rare in people under age 20. So when we talk about type 2, you know, we'll kind of see maybe a reason for that. You know, I mean, type 2 increases with age. We know that type 2 diabetes is related to the insulin cells, the beta cells, not being able to produce enough insulin. And so if we're constantly bombarding our system with sugar, and the body's trying to kick out, I mean, we're overworking our pancreas, eventually the pancreas is basically going to wear out. And so the other interesting fact is that 97% of all type 1 diabetes occur, 0 to 9 people that are, kids that are 0 to 9, diabetes is primarily type 1. And that's because type 1 diabetes is genetic. So as far as ages 10 to 19, we have 1 in 357 people with type 1 diabetes, being 81% diagnosed in that age group. Type 2, much less. This is another kind of startling fact, and that is that every 24 hours there's 5,200 new cases of diabetes diagnosed. So it's a disease that's constantly increasing. And then every 24 hours, 180 non-traumatic limb amputations, 133 people begin treatment for end-stage renal disease, and the 634 people die of diabetes-related complications. So one of the things, you know, as healthcare professionals, one of the things that I mentioned earlier is that, you know, I'm really enjoying in my practice educating my patients. I spend a lot of time talking about gum disease. We spend a lot of time finding out about their medical history. We give them a lot of literature to review. Diabetes is one of those areas where it has a significant impact on our dental patients, and we're seeing an increased number, as some slides will show you here in a minute. But obviously, preventing diabetes complications involves blood glucose control, blood pressure control, blood lipid control, and And this was rather staggering too. The estimated cost to the U.S. For diabetes is $174 billion annually. And then there's another condition called prediabetes, and it's a condition where the readings are not high enough. They're elevated, but they're not high enough consistently to be qualified as a diabetic patient. And so the studies are showing, though, that if you have a pre-diabetic state, I have to say I'm in that category, the incidence of type 2 increases, and also increase of cardiovascular disease. Losing weight, increased physical activity are those things that are going to help prevent that from happening. Okay, so there's also a condition called metabolic syndrome or metabolic disease that's occurring in the United States, and we're seeing an increased number of this as well. And metabolic disease is described as someone who has a body mass index of 30 or greater. They have two of the following: raised triglycerides greater than 150, reduced HDLs less than 40, raised blood pressure over 130 over 85 or higher, and then a raised fasting plasma glucose is greater than 100. So if you're overweight and your body mass index is 30 or greater, and you have two of these others, you are considered to have a metabolic disease. So again, think about this information in relationship to the patients that you are seeing. Because one of the other stark realities of diabetes is that there's probably about 78 million people walking around in the United States that have undiagnosed diabetes. They walk into your practice, they may have type 2 diabetes and not know it. People with metabolic syndrome are 2 to 3 times as likely to have a heart attack or stroke, 5 times as likely to develop type 2 diabetes compared with people without the syndrome. So we're seeing kind of an issue here that it's really important that we get involved with our medical counterparts to kind of educate patients on their nutrition, talk to them about their intake. Not only does it have an impact on our treating them, but it also has an impact on their overall well-being and health. So one of the reasons I think for increase that has been shown in some studies that have been done is that our dietary sugar intake has increased. We have a worldwide pandemic of obesity and cardiovascular disease, which leads to an association to metabolic disease, adverse health conditions. And it's interesting that our daily consumption of sugar has increased 20% over the last 35 years. We are a society that's in love with our sugar, and we have become the supersize me generation. And it's interesting. I think the other aspect of all of this, nutritionally, is that there are so many things that we consume, but we don't know what's inside them. We don't know that there's added sugars which may not be listed on the label. I did some research too. I can't imagine. I've got a Coke here, trying to keep me from passing out because of hypoglycemia. But you imagine taking the big gulp, which is 64 ounces or something like that, and drinking that. But I see people walking around with big gulps all the time. And generally, they're not filled with diet soda. They're filled with sugar-containing drinks. And then the other thing, I don't know how many of you go to Starbucks, but you don't have to raise your hand. The different things that they offer at Starbucks, have unbelievable amounts of calories. The frappuccinos, the cappuccino lattes, and the mochas, and all that. Whoop. So we're all going to try afterwards cappuccino latte, but they carry anywhere from 400 to 500 calories per. Obviously, that's the grande, the large, but I was surprised at that number of calories. And this also is the statement. This came from the International Diabetes Foundation. Paul Zimmett, I don't know who he is, but his name was attached to the statement, and that is, this is the first generation in which children may die before their parents. And so that's another thing for those patients or those in the dental profession who see young people. It's important to recognize that we do this definition for a child and for the adolescents, 3 or more of the following will qualify that person to be placed in the diagnosis of a metabolic disease or metabolic syndrome. So fasting blood sugar, overweight, triglycerides increased, and low HDLs and blood pressure high. So a lot of the hidden dietary sugars that we see are coming from high fructose corn syrup. They can add that to all of our drinks. They can add it in, oftentimes it's not. It's hidden, kind of in the little label down here. It's hidden, so they don't really tell you that it has that amount of sugar in there. So we need to try to learn how to read labels. There's been a 135% increase of consumption of sugary drinks over the last 25 years. And this is kind of interesting. If you were to take a natural orange and consume it as opposed to a cup of orange juice, you can see there's a distinction between the amount of sugar that's involved in that. Same with applesauce that's prepared, bar of milk chocolate. I think we need to become familiar with what we're putting in our body. Glycemic index is yes.
I just wanted to make a plug because we have this conversation with our parents all the time
Right.
about what kind of sugar is hiding. And most parents, if they look at a label that says there's 23 grams of sugar in there, they don't know what that means.
Right.
So I found a really good website called sugarstacks.com, and it takes a lot of these beverages and snack foods and regular foods, and it shows with sugar cubes what that actually translates to.
Yeah.
And so even, I'll encourage parents of, kindergartners and first and second graders to do this at home and find their favorite snack foods and see what's hiding. But like one Yoplait yogurt has 7 teaspoons of sugar in it.
Right.
You wouldn't know that just by looking at the grams.
Right.
So.
Right. I remember when fat-free yogurt came out, and it was like the biggest things, fat-free, great, it must be good for you, and then you look at the amount of sugar that's in there. And also, the other thing is you can qualify something as being sugar-free, but it has a non-glucose containing sugar sweetener in there that also elevates blood sugar. So, glycemic index is obviously something that's important because the higher the glycemic index, the quicker what you eat goes into the blood as glucose. And so, that's also something that we should be aware of. How many of you seen children, I know you guys do, in your practice? Are you noticing a trend that a lot of children seem to be getting heavier? Is that something that you're noticing?
Yeah.
And a lot of it has to do with the sugar-containing beverages that we are so enamored with. We bring so much of. Again, the glycemic index, it makes sense. I mean, white bread, you've always heard that whole wheat bread is better for you. One of the reasons is because it doesn't raise the blood sugar quite as quickly. White rice, so there's a lot of information that we can take home even to use for ourselves. By 2020, they project that 60% of all global disease is going to be because of obesity. With the trend that we're seeing now, there's less activity. We see, and I'll show you a survey that was done that kind of points to the fact that when you talk to parents about their children, how much actually gets home and gets implemented. So it's really quite a struggle, to educate, but that shouldn't discourage us from trying. Steve?
I read an interesting study where they asked parents who are obese and who have obese children, did they think their child was underweight, just right, or overweight? And almost all of them said their weight was just right.
Yeah.
So the perception, is kind of scary.
Yeah.
When a parent is evaluating your kid.
It's interesting. I mean, we see the same thing. I mean, you guys see it in your practice where, you get a patient who grew up in a home where going to the dentist was not that important, and generally they foster that type of belief, if you will, or activity, onto their children. And so people who overeat, who are overweight, tend to have children that are that way because children do what they see their parents do. And this is the other thing. 2/3 of the population are overweight. I told you earlier that I'm not 30 or above, but I'm about 28, so I'm considered to be overweight. And I've lost weight. But I'm still overweight, which I don't know. My wife says, if you lose any more weight, you're going to turn sideways and I'm not going to be able to see you. Not that much yet, but we should all strive to have a body mass index of 25 or less. And here's another chart that shows us the relationship between the level of obesity, the percentage of obesity in the population, and the amount of sugar consumption. So you can see there's a direct correlation. So, you know, just telling our patients they need to be aware of the effects, long-term effects. Impact of health, you know, consuming 3 to 4 sodas a day, 13% of the population do that. They have a higher body weight, they have lower nutrient intake, and they have worse health indices, which are related to triglycerides, blood sugar, blood pressure, and all of that. So the other thing that sugar has, you know, we consume low-fat foods, but we're not aware that sugar is actually transferred into triglycerides and to cholesterol. Then, you know, we're fighting a losing battle. I don't know if any of you have had in your practice, I mean, people who consume large amounts of alcohol, we know there's cirrhosis of the liver, which affects liver function dramatically. But there's also something that we can get, which is part of that metabolic disease we talked about, that people who consume too many calories and too much sugar, which elevates their blood sugar, impacts their pancreas, develop something called fatty liver, which creates the same type of medical issues that cirrhosis of the liver does. Anything that impacts liver function is going to impact us. You know, a tooth you're going to take out, surgery, you're going to do whatever. I mean, if this patient has a fatty liver, they may have bleeding issues, which, you know, if undiagnosed, you know, that creates a problem for you. This is the survey that I was talking about. So they came together, asked parents how they felt about their ability to increase fruits and vegetables in their children's diet. They asked about how well they thought that they could do about increasing their children's activity level. This next one is kind of interesting, whether or not they had confidence in the ability to decrease TV or computer use to 1 hour a day. And less than 50% responded in the affirmative. So a lot of parents feel like they have no control over bringing in positive changes into their children's lives. There's a few more that had confidence that they could remove the sugary drinks from their diet. But this creates an overall issue for dentistry. So one of the reasons that I wanted to talk about and why I think this is a great topic is that if we have an increased awareness, we can take that to our patients and we can educate them about the importance of nutrition. And I mentioned earlier about 1/3 of the adults with diabetes are undiagnosed. So that patient that comes in that doesn't list on their medical history that they're diabetic may in fact be diabetic. So, common oral signs, and this is something I see on occasion, and I don't know, some of you may have had an opportunity to see a patient who had periodontal disease, a lot of inflammation, you did some conservative therapy, root planing, what have you, and they just didn't seem to respond. And that is the patient that may well need to, after going through medical history with them, they may need to see their physician and have their blood sugar checked. But we see a lot of patients with diabetes that have recurrent oral infections, they're unresponsive to conventional therapy to treat the inflammation. They have an increased risk of developing lichen planus, which is another desquamative condition, recurrent apple stomatitis and oral fungal infections. And also, this is another thing that I thought that was interesting, but because in diabetes we have a lot more circulating glucose, that finds its way into the saliva, which can increase the caries experience of that patient. Also, diabetic patients seem to complain more of xerostomia or dry mouth. And then I'm noticing that in acute periodontal episodes, patients come in and they have more abscesses, more acute experiences, oftentimes requiring intervention and oral antibiotics. And I'm finding, and you you may have too, that the standard go-to antibiotics, PEMBK, amoxicillin, tetracyclines, just don't seem to be working as efficiently as they once did. So a lot of these patients require something a little bit more penetrating, like Keflex or other cephalosporins, clindamycin to treat these infections effectively. We see patients who have impaired wound healing. Has anybody ever had a patient come in who was not an alcoholic, who had like a fruity smell to their breath? Yeah. So that is an indication. You know, again, we have to ask our patient questions. I've had that, and sometimes it's because they are, and if they don't have in their medical history that I'm diabetic, they may be an undiagnosed diabetic. And so that's something that we need to talk to their physician about. Now, what do you think is the most common medical emergency that we see from a diabetic patient in the dental practice? Is it too much insulin, or I'm sorry, not too much, is it too much glucose, like I wouldn't know. So what is it? Hypoglycemia. Hypoglycemia is a condition where patients either have not eaten enough, they've taken their regular medication, and they get into a stressful environment, stressful situation, and the blood sugar drops. And so we need to be aware of what some of those signs and symptoms are. So weakness, sweating, mental confusion, which I may be experiencing here pretty soon. Incoordination, I have that all the time, so I don't know. Trembling, severe, sorry. And in severe, and in mental confusion too for these patients, sometimes sweating. Because severe hypoglycemia is classified as any blood sugar level that's 40 milligrams per deciliter or below. And that patient can go into convulsions or coma. So, really quick, I have a brother who is, what time are we stopping? What time? How much time?
About, let's say 10 minutes.
10. Okay, better wrap it up. Anyway, I have a brother who is type 2 diabetic, and he is a dental cripple. He lives in Arizona. He has an upper denture. Most of his lower teeth are gone. Unfortunate, but he doesn't take good care of himself. His diet has turned into, and this is going to lead up to why it's so important that we educate our patients, and that is that their systemic disease is directly related to their oral health. Loss of teeth creates issues for patients for their nutritional intake. My brother one morning took his medication, forgot to eat, and so he was being treated for hyperglycemia, but he didn't eat anything. He was driving to work, went the wrong direction, was swerving. I don't know why he didn't hit somebody or have an accident, I don't know, but he was pulled over by a physician. His blood sugar was 40 milligrams per deciliter. He should have by all means been in a coma or having convulsions or something, but you know, that's a real example to me of what hypoglycemia can do and how dangerous it is. He's had other accidents, luckily involving no other parties to the accident. But a lot of the medications, I'm going to go through these quickly. Glucophage, there's Januvia, Genumet, Gliza, Combigliza. We need to be aware of the medications that our patients are taking: Glucotrol, Diabeta, Actos, and Navandia, and then of course for those type 1 diabetics, insulin. So again, education, make sure the patient's aware of some of the signs and symptoms that may be manifesting as a diabetic, and to seek help if they have any of those manifestations. You know, it might be good for us to have even a blood glucose test strip. They're not super accurate, or even a glucose meter for those patients who are diabetic, or have the patient, like we do for a lot of our asthmatic patients, they bring their inhaler. Maybe we should have a diabetic patient that we're seeing for an appointment bring their diabetic meter so they can test themselves. We need to have an available glucose for the diabetic patient who may show or manifest signs. Can be anywhere from orange juice, tubes of frosting. I like that one. Can of non-dat soda, glucagon, and then I think I'm going to skip this, but basically, you know, the tube of frosting can be given under the tongue and it's readily absorbed, so it's a very quick way to get sugar into the obviously, if this ever occurred to me, I would stop the procedure. You would manage the medical emergency first, and then make the decision as to whether or not you could proceed after. I think it's important for the diabetic patient coordinate all the treatment with the physician, communicate anything that you see dentally to that patient's physician so that they can act on it and check the patient. A lot of these patients probably need to be on more frequent recalls. And one of the things that I like to just say is, I think with all of the systemic involvement of periodontal disease, oral inflammation, general body inflammation, I think we need to, as a profession, we need to look at inflammation as being our enemy. And for the diabetic patient, we shouldn't accept bleeding as being normal for that patient, because that can have a direct impact on their overall diabetic control. Frequent medical history updates, know what your patient's fasting blood glucose level is. And more importantly, most diabetic patients, especially insulin dependent, know what their hemoglobin A1C level is. And physicians try to keep their patients at 7 or below, and if anything is higher than that, then they need to go back to their physician for more aggressive diabetes control. This is the other thing, is I think that patients need to be educated that, I don't know if in your practice you have this, but sometimes a patient will come in and say, well, what do you mean it's going to cost me that much money to save that tooth? Can't I just pull it? That's the thing that they want to do, because it's easy, simple. They don't see the long-term effect of losing a tooth. So I think it's important that as dentists we educate the patient to the importance of nutrition in their overall ongoing health. And when they lose teeth, they lose that ability to provide themselves with adequate nutrition. Kind of like my brother, he saw foods. Soft foods are generally high glycemic, and so his diabetes is not controlled, and that's what our patients do. So we know that periodontal disease has been linked to a lot of systemic conditions, heart attack, increased risk factors, lung infections, low birth weight baby, newborns. They think that a lot of the epidemiological reasons for that is because of the inflammatory response in the mouth, increased cytokine production, which circulating cytokines actually increase plaque deposits in our arteries, which is one of the reasons why it's linked to cardiovascular disease and stroke. And we've had a lot of literature out there that talk about bacteria from periodontal pathogenic bacteria that's found in the plaque of a carotid artery or cardiac plaque after a fatal heart attack or stroke. So one of the things that, I hope you can see that, but the relationship, and you could say any sort of systemic disease, that it is going to have an impact on the oral condition of that patient. So it's important that we know what systemic conditions our patients have, how well controlled they are. And so if we treat that oral condition, then we have positive oral health. That positive oral health then affects the systemic condition. I've had a lot of occasions when I've had a patient come in who is diabetic, a lot of inflammation, and I've seen a direct positive result of reducing the inflammation, also reducing their blood sugar level. So controlling the periodontal disease and the inflammation in turn helps to control the diabetic state. And the same is in reverse too, that if they have a systemic condition, the better control they have of that condition, the greater chance they have of controlling their periodontal health. So anyway, I had a great time learning some of this stuff. It's for a lot of you, it's probably been some review, but I think, like I said, we can take some of this information and take it back to our practices and help educate our patients. Will improve everyone's general health. So thank you very much.
I think some of you guys might have some questions. I just wanted to say thank you, Dr. Wilson, for coming and talking about this topic. About 4 or 5 years ago, I was teaching at an Invisalign conference, and of all the just odd things that they were talking about, it was this kind of relationship between periodontal disease and straight teeth and all of this. And one of the things that really stood out during that conference was they were talking about how we see our patients 2, 3, or 4 times a year. They may not go to their physician but once a year.
have patients who are diabetic that are well controlled that have implants, and I think the quick answer to that is there's a lot of literature out there that says and indicates that historically diabetic patients do worse with dental implants. But that doesn't mean that they can't have a dental implant. I think they just need to be informed that there's a chance that they may experience more issues. Implantitis, periodontitis is one. I think we need to assess. One of the things about implant therapy that I see a lot of patients who come into my practice who have had other implants done. They have generalized periodontal disease, but a tooth was extracted, implant was put in its place. I think we need to look at the big picture, because as long as there's periodontal pathogens floating around the mouth, I think they need to be in better health before that implant goes in. And so that applies to a diabetic patient. They need to be in better control. It goes for the smoking patient. If the patient, again, it goes back to education. If they're educated and sign that informed consent that they understand these risks, then you've covered your bases. But the other thing is, I think it's important that that patient be seen very frequently to assess the level of oral health around natural teeth and implants. So I would not put an implant in. Now, if it was a patient who showed poor lack of treatment of self, their diabetes wasn't under good control, and they missed appointments, they were inconsistent, then I would think twice about putting the implant in. Good question. All right. Thanks again.
Thank you.
I do have 2 slides. Many of you I brought them to your table, but I have one slide that is entitled Various Cases. Those are all my cases, not all my cases. They're all my cases that are on there. I haven't captured those from somebody else, but it's one of the things that I love in the practice of periodontics is a lot of nutritional procedures. So that implant therapy, but you'll see a lot of the cases that I've done before and after photos, which might be interesting for you to look at. Then the other CD is Practice Resources. It just has a lot of the information, websites, PDF files that I took this presentation from. So you can take that back and use it. Anyway, have a great day.
Thank you. Thank you. I had my one and then I grabbed her other one. Is that in your purse?